Good morning, everybody. Thank you very much for that eloquent talk, Dr. Bilić. Keeping to time and keeping to make sure, so my job with Dr. Dikaris here is to keep the first session interesting, but get your coffee to all of you at the right time. So without further ado, I would like to invite Dr. Pfeiffer, who's going to discuss about surgery when there's no capsular support, how to solve the problem. So you're just diving deep straight into the surgery. Thank you, Dr. Pfeiffer.
Thank you. At first, I would like to thank Bilić Vision and especially Eva for the invitation. I'm very happy to be here again in Zagreb. So my talk is about the dislocated lenses and how do we implant the lens after that. We see that there are a lot of problems, and there are more and more. The incidence in Europe is rising, and also the numbers are higher of late subluxated intraocular lenses. So what is the reason? One of them, you can see there pharmacological, is also the glaucoma medication, anti-VEGF therapy, and antibiotics. Are those antibiotics that we are putting into the eye at the end of the surgery? Because this trend is not being seen in the US, but is seen in Europe. But we can go on. If we have a subluxated lens or a big zonule, what do? We can reposition the lens, or we can take the lens out and implant the new lens. And I'm going to speak mostly about the Amane and Canabrava, the latest techniques. There are other techniques that can be used, but the best is for the surgeon to use the technique he's best in, and this is also the best for his patient. So with these two techniques, what do we need? We need a special needle. It's a thin wall, 30 gauge needle. I'm using Sterimedics. Then I'm using a 23 gauge forceps. And for the Amane 3-piece IOL, I always have a 25 gauge infusion if possible, and doing subconjunctival anesthesia at the place of the tunnel. And sure, for Canabrava, we use 6-0 polypropylene, also 5 or 7 can be used. The lens I'm using is a Sensor Y because it's aberration-free and it has a round anterior edge. And it has also 10 degree volt of the haptics. But there are two other lenses, they have PMMA haptics. And these lenses has PVDF haptics that are more resistible, more friendly to the surgeon. This is Lucia and Avance from Kova. So let's go to the surgery. Here I want to show you the way I'm performing the Canabrava procedure. 2 millimeters behind the limbus, we use a 30 gauge needle to do a tunnel and introduce the 6-0 Prolin suture. This suture is then put onto the haptic of the intraocular lens. So I'm using here a 4-point fixation because with this fixation, I think I can be precise enough to implant also a toric IOL if needed. I wouldn't go for multifocal because the effective lens position is very questionable. So here we did this on 4 places on the haptic. The lens is implanted into the posterior chamber behind the iris. And now what we have to do are just flanges. Important in this technique is that tunnels...
This is the eye at the end of the surgery.
That the tunnel is done not perpendicular, but oblique.
Maybe if you can dim the light, please. The video will be better. Thank you very much. It's going to be better. Thank you. Excuse me, Vlad.
Okay, good. Okay, that's how it looks like at the end. Then let's go to the Amane technique. This is a child with ectopic lens. So with these ectopic lenses, what we do? We perform a small capsulorhexis in the middle. Here we see the intraoperative OCT. A small opening. Then we irrigate with viscoelastic and we aspirate using a aspiration device. and then the whole capsule is taken out. We do use triamcinolone, do the anterior vitrectomy, and then the procedure of the IOL implantation starts. In all cases, we mark exactly. Then we do mark the 2.3 millimeters behind the limbus for the children. The needles are bent, and we do the tunnel, limbus parallel tunnel. And now it's very important how we hold the instrument. I'm holding the forceps like this, not like this, but like a sword. Now the needle is oriented in the right direction, the bevel of the needle, so that we're able to put the haptic into the lumen of the needle. If you start, yes, this surgery was done somewhere in 19, and I wanted to find out the way how this needle can be stabilized. This is one of the ways I tried to do. Then the second tunnel is done, also limbus parallel on the other side. This needle is bent 80 degrees. So then I can do that repeatedly. Then the haptic is taken, it's put into the eye through 3 millimeter incision that the lens was implanted with, and now it's docked into the needle. So I think it's very important that the needles are thin, 30 gauge, because then the problems with the endophthalmitis or whatever are much less, and the wound is also closed. Now we are pulling the needles out in the same direction as they were brought in. As we see the left haptic on the left side, we release the left needle and do the flange on one side, on the other side. And since this lens was not perfectly centered at the end, we can just shorten the other haptic. And by doing that, we can perfectly center the IOL. This can be done also weeks after the surgery if you know where the haptic is. Therefore, I want to leave these haptics to be seen through the conjunctiva. It is buried into the sclera, but could be seen, and this is how it looks like at the end of the surgery. This is the same eye in this year with perfect visual acuity. After the surgery, he had just a cylinder. Now he grew up. He's a quite big guy now, and his diabetes is minus 2. So the technique, how I'm doing it today, we mark 180 degrees apart. Then, in normal individuals, 2 millimeters behind the limbus, first needle is bent 45 degrees. The second needle is bent around 80 degrees. The first needle goes away from me, the second towards me. Then the IOL is implanted onto the iris, into the anterior chamber, through the 3 millimeter incision. Now, I want to have the front haptic in the position that I can take it with the forceps. I'm using 23 gauge forceps for this. And as I said, it's very important to hold the forceps like this. So first tunnel, limbus parallel, redirect it, and now it's unedited. We grasp the haptic about 2.5 millimeters from the edge. Now I'm adjusting my left hand, and now the orientation of the bevel is very important. So we have to twist it, and then I'm pushing my left hand to get the haptic into the needle. Now the syringe is released from the needle. So it's much better control if you have needle on a syringe, and it's placed on the iris. I think that is the safest way, and there is very little chance that you lose the intraocular lens into the vitreous cavity with this technique. Then another tunnel, again, limbus parallel, and then we take about 2.5 millimeters from the edge of the haptic, bring it in, and dock it. And again, look how I'm changing the direction of the bevel of the needle to be able to put it in. So if you start the technique, you should try doing it out of the eye before the surgery, train it how to align the haptic and the needle to bring it out. And now, in the same direction as they went in, they're pulled out, the flanges are done, and we have a nicely centered intraocular lens at the end of the surgery, what you can see here. Okay. This is another case. It was done last Friday, not yesterday, but the week before. So here we have a fallen IOL into the retina, onto the macula, and here I'm using just a backflash cannula to hold the lens, bring it up into the pupil opening. I hold it with the 25 gauge instrument, and now I'm using a 23 gauge instrument to be able to open it enough and bring the lens into the anterior chamber. If you push the viscoelastic, with viscoelastic the iris back so the lens can be elevated, then it's cut into two pieces and is just taken out of the eye through 3 millimeter incision. Now the standard technique, we can do Yamane in as small pupil as possible. In every pupil it can be done because with the needle we open up the pupil and we have enough place to manipulate with the haptic and the needle. So again, the needle is placed on the iris. The second haptic is introduced into the chamber, and again, the orientation of the bevel is important. It takes me about 10 minutes to put the lens in. It's just a little bit more time than a normal cataract surgery, if the eye is aphakic already. And then we play a little bit with the needles to get the lens behind the iris. And again, the flanges are done, and this is how it looks at the end of the surgery. Here we had the paravalvular anesthesia, therefore some blood is there. The least resistible part of the procedure, I think, is the optic-haptic junction. Therefore, the Americans came with the idea of laser lock technique. And because I did reposition the lenses that were in the eye already for 10 years, and we had this location, the haptic went out of the optic. So I think with this procedure we did solve the problem. So here I want to show you another case where we use the technique to implant the artificial iris and the IOL in the post-traumatic aphakic eye. This was the injury. The patient had a vitrectomy done. The macula was fine. And we've decided to use the Yamane technique also to put the artificial iris onto the carrier. This is intraocular lens. And then the standard procedure of the Yamane technique or modified Yamane technique is performed. In this technique, we always have to have an infusion. We usually have a 50 millimeter of mercury of infusion, and when performing the tunnel, we go up to 30 millimeters. So both haptics are in the needle, and we just pull them out. It's important to pull in the same direction, otherwise we can harm the haptics and we would have a tilt at the end of the surgery. So the IOL and artificial iris complex centers very nicely, and this is how it looks like at the end. This patient is now, I think, 6 years after the surgery with very stable and good vision and position. And there you can see the haptic. So a little bit less than this will be perfect, because if we want to go for another surgery later on. The intraoperative OCT is very important to establish or to find out where the position of the artificial iris and the lens is. This is one of these cases. You saw the OCT before. And the very important, what I find in my hands is the intraoperative OCT when we implant this artificial iris to be sure that it is put in the right position and that there is no contact of the artificial iris IOL with the intraocular structure. So we go 360 degrees around. So in conclusion, these are things that I think are important. The last thing important was with this technique was the laser lock of the haptic, which will, I think, make this surgery more durable. So what to do? If you're good, I think the best is to do the technique that works best for you and your patient, but it's worth trying to come and do the new techniques. Thank you very much.
Questions at the end? Yeah.
You go. Okay, thank you, Vlado. The discussion and questions will be later. So it's my very pleasure to announce my co-partner here, Dr. Mantri from UK, and he's going to talk about spherical aberration and how are they shaping the future. We know that a lot of us do not understand too much about aberrations, so I'm sure this will clarify for us this story. Thank you very much.
Thank you, Doctor. Good morning, everybody. I'm delighted to be here from Vision Scotland and see this first refractive Zagreb meeting. I am a financial disclosure first. I'm a paid consultant to Alcon and Rayner. I think, so to give a bit of a background about me, I'm a consultant with cornea, cataract, and refractive surgery interest. I've worked in a teaching hospital in the NHS for about 20 years. Main interest was corneal transplant, whether it's lamellar keratoplasty or DMEC or DSEC. But latterly, I've moved to a private sector, having Vision Scotland in Central Belt and North of Scotland, offering private eye surgery for cataract, refractive lens exchange, refractive surgery, retinal surgery, the whole range, but privately. I think we all know if I think about my practice change in the last 10 years, if I had a patient with cataract or wanting lens exchange, if I think about somebody who's coming to me and said, I want my distance corrected, the main portfolio for me was always a monofocal or a monofocal toric lens. If they wanted a presbyopia corrected, if I think about 2 years ago, my probably practice was about 50% of these patients who were suitable to have trifocal lens. But what I found in probably the last 2 years, since the new technology has come in and we are able to adapt it and be less compromising for patients, I feel that the 50% of trifocal has now moved into almost 85% into the bracket of these extended range of vision patients and less of trifocal. Now, you want to do the best for your patient, and you want to therefore understand what's going on with this extended range of vision, because at the end of the day, a happy surgeon is only happy if you've got a happy patient. And I think all we want to do is basically give them the best technology that's out there. So I'm going to spend a bit of time. So the only two, there are few in the market, extended range of focus. You can call this in a very different name, extended depth of focus, extended range of focus. The two main I use is a preloaded hydrophilic Rayner EMV and a non-preloaded, but basically hydrophobic Vivity lens, which is a UV filter. These are the two lenses I've got experience about, and I'm just going to share my experience about EMV a bit more in detail. Now, if you think about, so you go away thinking, I want to know about this extended range of focus. What does every company tells us? So I think there is kind of eruption of technology or words that every company will use. And I think whether it's wavefront stretching or X-wave technology, or it's range of focus for EMV, or it's you're altering the spherical aberration, whether it's positive or negative, there are various ways you can achieve this. The first, I would say, technology that came onto the market was actually Symphony, which is a bit of a hybrid. It was the Eschlet technology, but the biggest loss there was it still had said multifocality. So there are a lot of patients who, what we found was they were not getting reading as good as a trifocal, but actually were getting a lot of glare. And that's where we moved away from it. But the terminology, in my opinion, is quite confusing, but the best way to understand is to understand spherical aberration. So I'm going to spend a bit of time understanding that. So what are the two categories of technology that's available? I said wavefront focusing or wavefront with Vivity, which is, you can say, X-wave technology, or either they use positive or negative spherical aberration. So negative spherical aberration, if you look at our, you've got Isopure, you've got iHands, you've got LuxSmart, they all use negative spherical aberration. I'm not going to go too much into that, but I'll go into positive spherical aberration and how we can use it to the benefit of our patients. And the Ray 1 EMV uses that. So if you've done both these lenses, you will see this difference. And I think the reason I'm going to spend a bit of time on that is to make, so if you look at this, this looks like a monofocal lens. If you said anything otherwise, raise your hand. I'm happy to, but I think this is truly looking like a monofocal lens. This, actually, if you put it in, it looks like a monofocal lens. If you slightly tilt it, or sometimes the patient looks up or down, you will see a bit of a depression or diffractive ring. And I don't know how many of you went to ESCRS, but there was a bench study presented by Damien Gettinel, and I thought that was very interesting. And actually, if you look at this bench analysis of these lenses, you see this flatter, so the distance is right in the center, and then you've got this gentle curve, which actually, the main difference here is this area here in the Vivity, where there's almost a 1 micron rise in that bench analysis, which kind of corresponds to the diffractive ring and can give you some dysphotopsia. So it's quite an important thing that in the bench analysis, it shows that there is some degree of diffractive in this ring. But how does it do what it does? So for eye, we know as you're getting older, the two aberrations in the eye is corneal spherical aberration, which is about 0.27, and the negative spherical aberration caused by a natural lens. Now, the natural lens of a 25-year-old versus a 50-year-old, that negative spherical aberration keeps on getting, or it gets less and less along the way. So the positive spherical aberration then becomes, is the bit which gives you a bit of pseudo-accommodation. So all the monofocal lenses just use positive spherical aberration from the cornea, but if you were to add a positive spherical aberration to this in the therapeutic range, then what you will get is the circle of least confusion. So this area where it's saying 1.5, that's the circle of least confusion. And you really wanted to have that range and use it to benefit for the patient, rather than just a 0.5, which is the pseudo-accommodation you can get with any aspheric monofocal lens. And I think the simple idea of this was put along by Prof. Barrett, and he's obviously patented work with Rayner, and effectively what he's done is using this as a platform. But the biggest advantage, I would say, is it does behave like a monofocal, i.e. it is very forgiving in terms of tilt, decentration. The dysphotopsia is minimal. And I think that's kind of the key, where as surgeons, we feel we can predictably tell the patient that there's less risk of dysphotopsia, and it's actually all benefit compared to a monofocal lens than a multifocal lens. So just to get a bit more deeper into that, I've got some colleagues who say, well, why use an enhanced monofocal lens? Why not just go for if somebody tolerates monovision? So if you look at this, a standard monofocal, the biggest advantage is you've got this MTF curve, and you see a very, very sharp distance, but it quickly falls over. So there's no range of, if that's on the left is the distance and on the right is the near, it just falls very quickly. How does a positive spherical aberration in EMV causes this to be better? All it does is it flattens the distance bit more towards myopia, so you're flattening and moving it across. But more importantly, the near bit, or the distance bit, there is like a hyperopic tail. So it flattens it and moves it more towards the distance, so it does not compromise the distance as well. So the difference between this and this is, though it's flatter, but it's broader, and it moves towards myopia and with a hyperopic tail. Now that's used very well if you look at the monovision. So if you had a patient whom you wanted to do dominant eye for plano and non-dominant eye for -1.5. So that's kind of the monovision that you would want to go. The only problem is they do very well. They do very well for distance. They do very well for here. But all this range of vision is empty. So that's where the blend zone is minimal. Now, with the same principle as spherical aberration, how positive spherical aberration is helping, if you think now the difference with the same plano for distance and monovision for the non-dominant eye, because of the hyperopic tail, you actually end up having a much, much bigger blend zone, but not compromising the distance as well. So this is where I think all this EDOF technology has been very helpful for us. And I think this bigger zone is, again, thing that if you were doing laser and presbyon, that's where you kind of think you want to be in that blend zone where both the eyes work together, but actually it does have a range of focus rather than a very sharp sharp distance, but nothing in between. So I hope that makes it a bit more clearer for you. If you are one who's starting to think, well, I have never done EDOF technology, I want to start it. So for me, I think this is the full range that you would want to think about. You can either do emmetropia for both eyes. I think most people would prefer. So if I was the surgeon starting a new EMV or Vivity, I would just do a good dominance test, do a dominant eye for plano and non-dominant eye for -0.5. Do not promise the patient anything more than 0.3 logmar, like N10, and 6.6 to 0.00 logmar. I would say if you are promising that region, the risk of you inducing any risk is much less, but actually then you can build your confidence up and start doing more with it. So For me, I would say a modest monovision will go up to minus 1.25 in the non-dominant eye, and a full monovision is minus 1.5. And with that blend zone, you can actually make it work, and I've got some results to show that. I think we all know, and toric lens is probably a discussion on its own, but for any premium lens that you use, whether it's trifocal or extended depth of focus or extended range of vision, you need to not kill the cell, but you need to reduce the astigmatism, because otherwise, if you don't have the sharp focus, it will probably, it will not give you the result that you want. So for me, if you got anything astigmatism less than 0.75, I would actually either go on axis or do flex, femtosecond guided limbal relaxing incision or arcuate keratotomy, depending on what the patient is. But now both these lenses, EMV or Vivity, have toric platform, and the results are very, very good, and it's very stable. We all know from their monofocal counterparts that the toric lens is very, very stable. So quite confident but you need to, the only place where, so I think if you've got astigmatism on a corneal plane, which is more than one, and it's against the rule, like a horizontal axis, you need to use a toric lens. If you don't have toric lens, I think you will not get the result that you desire, and I would rather stick to monofocal toric lens and say we cannot give you distance vision. I think if your toric lens can't be, or astigmatism can't be corrected, I don't think you'll get the desired outcome. If you do have some residual astigmatism against the rule, sometimes the circle of less confusion and optically the strum of conoid can give you a bit more depth of focus. So I think if you had some residual astigmatism, it will work. But usually, you'd want to reduce the astigmatism while you're doing these premium lenses. I think with all that said, I think I'm going to present my 100 eyes with EMV that I've done. And I think it's quite important to, though you ideally want binocular vision, it's important to say that it is very, so if I was to say the color coding, emetropia is the blue on that, the light blue is monovision, mini monovision, which is about -0.5, and the orange one here is modest monovision, is up to -1.25, and the full monovision is the pink there. And you can automatically see, unaided wise, the distance is the best in the emetropic group, and the near is the best in the full monovision group. That's understandable when it goes to unilateral. But life is not about unilateral. You don't walk with this one eye like that. Life is about binocular. And I think it's very interesting for me, even as a surgeon, if you look at the one on the left, it's quite important, because even if you've got full monovision there, it's not actually affected the distance. If you look at this graph, binocular unaided distance vision, they're all hovering around 0.000 logmar. So your distance is not compromised with both eyes open, which should give us a confidence thinking, actually, if the patient is very, very keen on reading and will adapt a bit of a monovision, then I think you can stretch the monovision with more experience you've got. The other thing which I feel is very, very good to say here is overall, the reason I've put both logmar and N is I understand in Britain we still use N4, N5 for reading, and I would say almost 100 patients, 100% of the patients got better than N6 or better, which I feel is something which you can almost coming very, very close to a trifocal vision. However, the trifocal doesn't give you, well, the risk with trifocal and the glare is massive. Now, on that point, I would say trifocal is not there. I've done my business partner's mother and mother-in-law both with trifocal, and they're the happiest patients. They basically, they know I like my wine, and they basically send me carrots of wine, and it's coming every 6 months, so they must be happy. So I wouldn't discourage you to use trifocal, but wherever you feel either you're coming into the presbyopic market, or you actually think, I don't want to take a risk about somebody, depending on like a commercial pilot or somebody who's an HGV driver, you don't want to take a risk of trifocal in that. Whenever you try a new lens, and for us, when we were trying EMV, you always want to make sure you optimize the constant. So I'm working with Prof. Barrett and Rainer to optimize my constant. I think overall, it looks like the EMV is fine. EMV toric, we may have to slightly reduce the A constant, but I would strongly encourage you to collect your results and actually optimize your A constant, whichever lens you're using. And I think, you know, that's for all of us. Just putting it another way, I just think I'm going to just not keep on hovering about the results, but just to say, overall, 100% of patients were getting as good as 0.1 logMAR, and for near, 92% got better than N8. And effectively, what it gives me the confidence is somebody who's coming to you and saying, I want to get this lens, but I want to do all my normal activities like seeing the dashboard, watching the phone, and the smart, you know, a smartphone, and they're reading the text. That's actually pretty much most of our life nowadays. That's what we do. This dashboard, driving, and it doesn't give you dysphotopsia. So I think it gives you the confidence that all these lenses, extended range of focus lenses, are actually here to stay, and we just keep on working on it and make it bespoke for patients as we go along. So I think before I finish, I just thought I'll share with you this result from Oliver Findle, president of ESCRS, who presented in ESCRS, and I like this graph. And he compared the photopic and mesopic, so during light conditions and during dark, between EMV and Vivity, the two lenses that most people are using at the moment. And I would say, overall, as you would expect, the distance and intermediate is the same. The near is slightly better with Vivity, and if you compare that with the halometer or dysphotopsia risk, they're statistically significantly higher in Vivity, which actually kind of ties in with what Gatinel said as well, that there is a bit of a diffractive ring. It has slightly more risk of dysphotopsia, but gives you a bit better reading in that scenario. So it all probably ties up in terms of objective bench analysis versus subjective what you see in real life. And I think if you just need to put, I think we should give our patients the best choice that we can, depending on what they want, actually. So depending on what their job is, you can use these results to your benefit. I think I've got a couple of cases just to show that where we've moved from trifocal to giving. So if I had a commercial pilot before coming to me, coming for a refractive lens exchange, I don't think I would have considered them suitable, because I couldn't have given them a trifocal, because you cannot give glare to a commercial pilot and then go on that plane to going to Singapore on that flight and he's got glare. You don't want that. So this chap, as a self-referral, he came along, he said, I'm a professional pilot, now RLE is allowed. He had gone on the FDA website and he had said to me that the two lenses I'm allowed to have is either IHANS or EMV, because it's enhanced monofocal and it's been allowed, so the commercial pilots are allowed to have it. So he came to me saying, I can either have these two lenses only. And very surprisingly, there's not many opticians who use EDOF contact lenses, but he actually was using EDOF contact lenses. And he said, I've adapted really well to it, so I'm going to try this. Anyway, for me, I think as a refractive surgeon, I think the challenging thing was he wanted vision correction. Obviously, he had a demanding job. He really looked for precision. Commercial pilots are very they are obsessed about things, and that's how they are what they do. So it was quite tricky for me to get this, but I did. So my plan was to do the dominant eye, aim for plano, and the non-dominant eye for minus 0.25 or minus 0.5. However, he did say to me that he cannot have the non-dominant eye or any eye unaided 6/9 or worse. So basically, he ended up having emmetropic in both eyes, and I'm pleased to say that was his level of vision. And he's given me, again, he's given the team and everybody so many thank you cards. that he's been delighted and he feels has been, and I think more commercial pilots will come along the way asking that, because this is something which, but we couldn't have done that for trifocal. You know, I think we all are nervous when it comes to the patients we have lasered or somebody else is lasered and then they come with a cataract. The problem with that is they still want absolutely spectacle independence, because that's why they got the laser in the first place, and they become a lot more difficult. So this 65-year-old, the right eye was the dominant eye, and the left eye was the non-dominant eye. The left eye had good vision, had very early cataract. So I had said to him that I probably would be able to do an EDOF lens for you, but if I don't get my precision right or the refractive result right, then I might actually have to do the other eye to balance the two eyes together. And you know, the only thing I don't have here for this case is what was the corneal spherical aberration on the pentacam. I think it was still in the therapeutic range, and that's why I decided to add the positive spherical aberration. So we did with EMV toric, and he was 6/7.5 and N6 unaided with that eye, and he decided not to go ahead with the other one, which actually, in my opinion, was a very good result, because I had to do the other eye only to make sure with both eyes open they will be fine. So the dominant eye then was almost around 0.1 logmar and 0.3 in terms of reading, and he was a happy patient. One last case, this 83-year-old, normally, if you've got cataract, we've got very, very early dry AMD, the more OCTs we do, the more epiretinal membrane we see. Not very, very subtle, but actually, when you've seen it in OCT, you've got to document that there is an epiretinal membrane. Patient is not symptomatic, there's very less clinical signs, but OCT is showing you a bit of a, you know, the fovea is not right, and there's a very early epiretinal membrane. Previously, I would just do a monofocal lens on this one I did an EMV for this one, and he got bilateral cataract surgery the same time with EMV toric, and you know, again, there was a dry AMD, so I'd always said you would not get 20/20 vision, but actually was very close to 0.1 logmar distance vision, and I think it expected, I think the expectation was exceeded in patients' words. So I think if any one of you are thinking of doing extended range of vision lens, I would always say you could actually make it very, very specific for or individually or bespoke make it for patients. If they're really pilots, they don't want any compromise with their distance, like HGV drivers, pilots, I would say aim for plano. If you've got golfers who really want to have a round of golf and then have read the paper and want the dashboard, you could do a micro monovision. However, if you then have people who are chefs or gardeners, they're doing a lot more near activity, a lot of artists, I think then you start thinking about doing a monovision trial and giving them modest monovision or a full monovision. And actually, you're quite, as you'll see from the results, that the distance doesn't get affected that much. So it's worth just pushing that boundary and making it to full monovision for these patients. So in conclusion, I think it's a growing segment in my practice, and I'm sure most of you who are into refractive surgery and premium lenses, you will also agree that if you did trifocal 50% before, you're now doing more and more of extended range of focus now. And partly, in my opinion, the reason, so I use both EMV and Vivity, but I feel the one thing which has been quite good for is truly it behaves like an enhanced monofocal. And the reduced dysphotopsia, high contrast sensitivity, and I actually think also I'm getting less chair time because I'm saying to them, at worst, you have to wear some reading glasses for fine reading, and they're fine with it. We don't have to spend that much time talking about dysphotopsia, which is quite an important part of your trifocal sort of consultation. So I think I was speaking to Luca, I was just saying, I am actually going to do, because I think all of us want to know how we can carry on doing EMV or IHANS and Vivity, and I'm starting a study between doing the cost-benefit analysis for the clinic and the patient, which hopefully, watch the space, it'll be arriving soon. Thank you very much for having me. It's lovely to see you. Thank you.
Shall we proceed? Shall we proceed with Nadezhda Bilić, please? It's a pleasure to announce my chief, my dear chief, to talk about femtolaser cataract surgery, pros and cons.
Thank you, Eva. Thank you, Sanjay. It's a fantastic presentation of different lenses from your practice and from your big experience. We are not going to talk now about any lenses in this lecture. We are going to talk about the methods that we are using in our polyclinic for cataract surgery and for the refractive lens exchange or a clear lens exchange. Today, in developed countries, femtolaser-assisted cataract surgery has been a standard procedure for some years. It set new norms for precision and smoothness of cataract surgery. However, there are still ongoing debate about the real advantage of femtosecond laser-assisted surgery and a certain gap between theoretical and demonstrable advantages in clinical results, all underlined by the financial cost-benefit aspects. Fortunately, it is what we meet every day. Flex method was introduced by NAJ in 2008 and approved by FDA in 2010. Application of the femtosecond laser evolved from flap creation in LASIK to flex femtosecond laser-assisted cataract surgery and occurs in 3 steps: corneal incisions, anterior capsulotomy, and lens fragmentation. The remaining surgical steps still require the surgical hands. What is femtolaser surgery? The computer focuses the laser under the control of the OCT in real time, which allows the device to do the necessary. Femtosecond laser pulses are similar but shorter than those of the neodymium Jaeger and ultrafast that cause breaking of the bonds between electrons at atomic nuclei, producing bubbles. Pulses are too brief to transfer heat and generate inflammation to the tissue, so they are suitable to cleave tissue. Theoretical advantages of such process are enormous. Always perfectly positioned and designed corneal incisions are more predictable in addressing postoperative astigmatism and better close the anterior chamber. Arcuate incisions that remove residual astigmatism are safer and more efficiently than manual incision. A capsulorhexis that is always safe, repeatable, perfectly centered and shaped, which is very important for premium IOLs. Fragmentation of the lens facilities phacoemulsification and reduces the need for ultrasound energy, which has a beneficial effect on corneal stress, loss of endothelial cells, and the speed of postoperative corneal recovery. We analyzed 300 flex surgeries in our facility with the LensX platform from Alcon done in our polyclinic. The 3 surgeons in 2 years period will give insight into advantages and disadvantages of this method from our experience. Postoperatively, we first tested uncorrected visual acuity and best corrected visual acuity. After 1 and 6 months, greater percentage of patients achieved postoperative refraction within plus minus 0.50 diopters of the target, 90% in group of flex, compared to 71 in manual. For patients, the most important criterion for the success of the operation is postoperative visual acuity. He doesn't care what method do you use. He cared about what kind of doctor are you? Are you a good surgeon? And also, is he going the best quality lens? But at the end, he always wants to know how he or she will see. I want just only to trace few of the studies. In 2016, Chen get these studies in meta-analysis in favor of flex over conventional surgery. 2017, yeah, and others, also meta-analysis indicates superiority of the flex, particularly in terms of corrected best visual acuity. But also there are some who opposed. 2019 FEMCAT study from France showed advantage of flex over conventional surgery, but 2020 Kolb and others in meta-analysis suggest that the advantage of flex are just temporary, lasting up to 6 months after the operation. A big part of the problem is in translating the precision and consistency of the femto procedure is better visual acuity is related to the relative inaccuracy in the calculation of the intraocular lens, mostly due to the still unpredictable effective lens position. We are using several machines for calculating. I would say the majority we use Zeiss IOL Master 700 and Barrett formulas. The consistency of femto-assisted operations is likely to be significantly enhanced when the method of calculation of IOL power and efficient lens position is tailored in the future, especially to the femto procedure, and leverages its predictability, also in the study of Lawless at 2017. The advantages of flex are more pronounced in refractive procedures, in the removal of refractive errors using intraocular lenses for distance or near vision, and generally in the implantation of high-tech lenses, we call them premium lenses, such as trifocals, toric, extended depth of focus, etc. Optimally centered, perfectly round, capsulorhexig results in the aforementioned reduced higher order aberrations and better IOL centration in Chen's study anterior segment OCT. When we talk about corneal endothelium, a statistically significant difference in the loss of endothelial cells was demonstrated in favor of the flex procedure due to the less required ultrasound energy, which is well known, and the general manipulation during the lens removal. You see now the other studies also have their own investigations. The long-term results of maintaining the vitality of the endothelium are especially significant, as Kolb and others showed in meta-analysis in 2020. These benefits are particularly pronounced in patients with fewer or diseased endothelial cells, hard nuclei, and shallow anterior chamber, also according to the studies. Dry eye testing pre- and post-operatively, this is what we do on a regular basis in our polyclinic. We use tear check technology and saw no significant difference between flex versus manual group. Dryness usually ended within the first 2 to 4 weeks post-operatively after both methods. Now you see, this is what we are testing: tear film stability evaluation, NIBUT, then ocular surface inflammation evaluation, zatim abortive blinking, eye redness, Demodex, lower myopography. Everything is tested before and post-operatively. When we talk about complications, pupillar reconstruction, incidence of pupillar reconstruction was 25%, and the rise during the first steps of the femtolaser procedures, as laser application itself can cause pupillary meiosis. Bubble formation in the anterior chamber releases small amount of free radicals and prostaglandins, which can trigger pupillary constriction. But intracameral epinephrine before lens removal can help enlarge the pupil, or using malleolus ring or iris hooks, especially in high myopia and PECs. Posterior capsular rupture during the flex. In our group, there were no PCR during flex cataract surgery. In different studies, incidence is very low, 0.02%, with vitreous loss rate from 0.65 versus 1.65% in flex group compared to manual cataract surgery. Complications related to the posterior capsule have been proven also to be fewer in flex, as also we tested in also the same results had in our patients. As evidenced by a series of studies conducted between 2016 to 2020, included 2 randomized controlled trials. Sorry. When we talk about advantages of flex, it is on the first place precision and predictability regarding capsulotomy size and centration, better position of the lens and lower possibility of the lens tilt and decentration, corneal wound construction and nucleus fragmentation, less energy delivered in the eye than during manual cataract surgery. We saw that flux can reduce the postoperative endothelial cell loss in high-risk groups like Fuchs dystrophy or similar. In this flex group, a month after surgery, there was no significant loss of endothelial cells. But in early postoperative period, patients in flex group see better than in manual group. That is our opinion. And quicker healing and recovery of the eye, better adaptation, more precise. Femto-assisted cataract surgery in complicated cases. Various authors describe the advantages of the flex procedure in more complicated cases, involved hard nucleic cataract, then shallow anterior chamber, suboptimal corneal endothelium, unstable zonal subluxated lenses, identification of unstable zonal on OCT, and minimal surgical stress, PECs, and also very good in pediatric operations. Disadvantages are costs and are much higher for flex than for manual surgery, construction of the pupil before lens extraction, which can be a problem for not very experienced surgeon, dependent on wide pupil, which must be more than 4.6 millimeters. In conclusion, femtosecond laser is still a young procedure comparing to phacoemulsification, a very mature one. Progress in the laser technology in ophthalmology is expected in the miniaturization of lasers, making them more movable. New lenses may be designed based on its precision in laser axis and wound open, and will open a new refractive era, giving significant advantages to the laser procedure. Because the cost effectiveness is still questioned, many countries cannot afford or consider adopting this technology yet. If adequate improvements are achieved in the future concerning flex technology compared to femtolaser technology compared to phaco, this technique may become the gold standard one day. These are Luca's personal experience. Flex has become a routine part of our cataract in refractive practice for the last 4 years. Around 1/3% of patients opt for flex procedure. Out of 300 flex procedures in the last 4 years, there was 0 PCR complication. Today, especially for young patients with best corrected visual acuity of 1.0, coming for refractive surgery and clear lens extraction, the flex procedure is my first choice. Also, Luca's experience, femto-induced meiosis and challenging cortex removal, in my opinion, do not make flex particularly suitable tool for beginners. The learning curve definitely exists. All our surgeons were experienced phaco surgeons when helped them in mastering flex, what helped them in mastering flex. Once the technique is mastered and patient selection criteria are adhered to, primarily having a sufficiently wide pupil, flex is a useful tool, especially in a refractive surgery practice. Thank you.
Thank you, Dr. Bilić, to do a comprehensive lecture on femtosecond, very well covered. And now we'll go further on. Dr. Dikaris is going to speak on femtosecond laser for cataract and Fuchs endothelial dystrophy. Thank you.
Thank you. Thank you, dear colleagues, dear co-chairperson. Well, first when femto came into our lives, I was a bit skeptic, and I said, that's a very, very expensive knife. What do we need it for? But this was exactly the same what I said about automatic cars. It's just for fools, and I'm driving it now. So frankly speaking, with the time when you start to use something, you can see the advantages of the tool, whatever it is. So the topic that I would like to share with you today is use of flux in eyes with corneal disease, Fuchs corneal dystrophy. So in fact, how often are we faced with a cataract combined with FED? And in my hands, it's around 8% of all cataract surgeries that we perform. And therefore, we have analyzed whether flux can help us in those difficult eyes. So we have analyzed whether femtosecond flux surgery can improve the outcome in our patients regarding absolute and effective phaco power, of course, vision, post-phaco EC loss, and change in morphology of the cornea, and then a potential need for second surgery being endothelial graft. So therefore, we have prospectively followed up two groups of patients, one operated by flux and the other operated with conventional phacosurgery. And as you can see on this slide, there was no statistical difference between the age, EC density, pachymetry, or acuity at which patients were submitted to surgery, be it one or other way. So looking at the number of endothelium, we always talk about number. It's not just the number when we look at the cornea, it's also the quality of the endothelium. And this is shown on this slide. For example, this cornea with a nice number of cells, with a low, number of cells of only 11,000, but very nicely shaped cells with nice morphology compared to, for example, top right side, a cornea with almost 2,000 cells. You would say, great, no problem. However, this cornea has many gutta, bad morphology, and I would bet that this cornea would decompensate prior to the cornea with 11,000 cells. So with the use of femtolaser, we really want to spare as much endothelium as we can during the surgery. So none of the cataracts that we did had a hard cataract. The surgical approach is to use a lot of dispersive OVD many times during the surgery, phaco chop with torsional phaco. And as you can see on this video, the phaco phase is very quick. And then we aim for IOL power slightly myopic. Potentially, those patients might need EK. So this was aimed to diminish the loss of ECD. And post-op, those patients are seen more regularly than the standard one. They have a little bit more steroids. I always use topical hyperosmotic agents. And in post-op recovery, mannitol infusions if needed. So looking at the results, when we compare mean absolute and effective phaco power, it is, as expected, significantly lower when we use femto as compared to conventional phaco. And looking at the visual recovery, so patients operated by flux are represented by red line, and patients by conventional phaco by the green line. And you can see that the vision gets better quicker and stays in a higher level in flux patients compared to the conventional phaco. Looking at one specific patient, you can see on a slit lamp the cataract and the very visible Fuchs in this case, and the image of his endothelium. And what happens post-op, really bad at the first post-op day with just 0.1 vision and a lot of decimate folds, and a cornea of 760 microns. And this patient was submitted to flux. However, fortunately enough for him and me, At 1 month post-surgery, he can see 100%, cornea goes back to 600 microns, and the loss of cells is pretty decent, 9%. However, with conventional phaco, it tends to be worse. So the patient on first day post-op, in this case, similar FED situation, almost 900 microns cornea, a bad vision of 0.1, getting a bit better after 1 week, after 2 weeks, and finally, at 1 month, this patient is still struggling for vision, having just 0.6 vision, and he was submitted to conventional phaco. So maybe the best comparison, in my view, is to have one patient operated by 2 methods and having FED, and this is one such a case. This is his flux eye at 1 week with a vision of 0.8, and historical image of his phaco eye with vision of just 0.2. And at 1 month after the surgery, still significant difference in a visual outcome and appearance of the cornea when flux is used better. So looking at the numbers, endothelial cell count in this group of patients is throughout 3 post-op months higher in patients operated by flux and represented by red than by conventional phaco. And in numbers, that means that loss of cells in flux was on average 9%, and with phaco alone, 14% on average. And one more endothelium. Images, I think, always tell it all. This is one post-CPS endothelium, so conventional phaco, quite bad image before surgery, and after cataract surgery, this patient have lost almost 20% of cells, so quite bad for him. And after flux, similar patient with similar number of cells, pre-op, 1 week post-op, and 1 month post-op, and the loss of cells is significantly lower. So the difference between 9% loss and 18% loss, maybe it's not such a big deal in a cornea with 3,000 cells. However, in a borderline corneas, this can make a difference between corneal decompensation or nice cornea. So the absolute number of cells does not tell it all. I repeat once again, because many publications always speak about number. But look at those 2 corneas. These are post-cataract surgery corneas with approximately the same number, and the fool can see how huge the difference is. So to conclude, it is wise not to postpone phaco in patients with Fuchs. Very often I have patients, because I do also cornea, coming to me, I was advised not to have cataract surgery because I have FED. Very nice, but what will you do 3 years afterwards? You will have a hard cataract and your cornea will be gone definitely. So it's not wise to postpone phaco in FED eyes. Flux will ensure better vision and lower EC loss. And this is, in my view, especially important if we look at endothelium and we have bad cell morphology. And finally, none of the FED eyes in a follow-up 9 of 9 months did need endothelial keratoplasty. And when we talk to our patients and suggest them to have flux, the one issue that we always discuss, that the chance that he or she will not have second surgery is better for him if he goes for flux. Looking at the literature, as always, more you read, more confused you are. So you have a paper saying that flux is better, and then there is a paper also saying that there is no significant difference, talking only about FED eyes. However, when you read the paper, in the paper, when flux was shown not to be better, all the patients had EC count of around 2,500. So it's a completely different story from the group of patients I have shown you with less than 800 cells. And I thank you very much for your kind attention.
Thank you, Dr. Dekaris. We'll invite Dr. Pusnik now to speak about management of atrophic floppy iris during phaco surgery. Thank you, Dr. Pusnik.
Hello. I'd like to share with you my approach to the atrophic irises. Atrophic iris happens because because of the changes of the tone of the musculus dilator, and this atrophy could be that these muscles are 30% thinner. And this can happen because of drugs, infections, glaucoma, and also the rigidity of the vascular vessels. This is one example of this adrenoreceptor antagonist tamsulosin, which induces disuse atrophy of the iris dilator smooth muscle. Let's quick jump to the anatomy of the iris. Iris has two layers and stroma and double-layered pigment epithelium. Stroma contains two types of muscles, musculus sphincter and musculus dilator. Musculus dilator is much more exposed to any movement of the fluidics in the anterior chamber. And also, it's very this minor arterial circle could be also the reason for rigidity of the iris sphincter. According to the atrophic iris, we have this IFIS, intraoperative iris floppy syndrome, which includes floppy iris, tendency of iris to prolapse, and pupil constriction during the surgery. So the main task for the surgeons is to keep this atrophic iris or the surgery under control. And how to cope with this atrophic iris? My suggestion is that the incisions or incisions must be longer. At the 1.2 length side port incision, I suggest 2 millimeter. At 2.2 main incision, my suggestion is 3 millimeters because of this area of the iris which is a candidate for prolapsing. So if you have this shorter incision, we have much more tissue of iris for prolapsing, and we have worse control. And when we have a longer incision, then there is less tissue for prolapsing, and you have better control. I always inject epinephrine into the eye. I prefer epinephrine into the patient than in my body. So whatever, if it's even a small amount of mydriasis, it's better than nothing. So steps are here. Sometimes you have to color the capsule. I use a lot of viscoelastic, and I do capsulorrhexis with a needle. And my main incision is always not totally done, but in partly. So the inner part of the incision is only 1.2 millimeter wide, and have better control over the anterior chamber and prolapsing of the iris. And I always, in such cases, if epinephrine doesn't work, I use this stretching of the pupil. Sometimes it's enough in one direction. Sometimes you can do it in two perpendicular directions. And viscoelastic also widen the pupil as well. So put this viscoelastic is your third hand. Well, you have different approaches with these rings. Well, compare this Malugin ring structure of the Malugin ring with the tenderness of the iris. It is quite tough and hard structure, and it can happen. It can induce some hemorrhage from the eye angle. So I try with this Malugin ring several cataracts, but I don't use anymore. We have first generation Malugin, this is first generation. Second generation is better and softer and have a tender structure. And this B-hex pupil expander is better. I think it's, the structure is thin and tender, and I think it's better for iris tissue. Well, for explanting, there's some effect on the iris as well. You can have also possibility with these hooks. And with these hooks, with 4 hooks, you can do different shapes. And one shape is this diamond-shaped and square-shaped pupil. Well, surgeons prefer this diamond shape because there's less damage to the iris muscles. And yeah, okay, ladies like this diamond shape more. And in very tough cases where the sphincter is very rigid, I use this small cuts of the micro scissors. And if you have such a case with posterior synechia, you can freely release this synechia without destroying anterior capsule because of the double-layered anterior structure of the posterior anterior capsule. And if you are not careful enough, look at when you are moving this phaco tip too far behind, you can induce iatrogenic iridotomy. Just a moment, look here, oops. And I induce this injury to the pupillary sphincter. So you must be careful much more when you are dealing with atrophic eyes. And how to get into the eye with, when you have atrophic and prolapse of the iris with pedal step irrigation 1 inside. And this, the distance between the top of the tip and the sleeve is less than 1 millimeter. Okay, here are some techniques how to cope with remnants of the lens in the eye. Just irrigation, or you can remove this by manually as well. It's better by manually. Yeah? You have much better control over the eye. So in summary, my suggestions: longer incisions, two side ports and many incisions. Think about the area of the iris under the inner rim of the incision. I use lidocaine intracameral always to induce less pain to the patients. Epinephrine is my goal. Stretching. I do not use anymore this extension rings, and I do this many incision in 2 parts. There is less leakage of the viscoelastic. These are my suggestions. Any comments? Any suggestions? Okay, thank you. Right.
Thank you very much, and it's a pleasure to introduce Dr. Predović, who is going to talk about diabetic cataract sweet challenge. We like it sweet.
Yeah, I thought you needed something sweet now. Thank you for an invitation, dear colleagues. So I'll talk from perspective of retina surgeon and retina specialist. So the next slide. I'll remind you about diabetes and later talk about peculiarities of cataract surgery in diabetic patients. Like you know, we don't treat only eye in diabetic patients, but it's a microvascular angiopathy of all organ systems. You have to keep it in mind. So nowadays, the diabetes is a growing problem worldwide, and it is a great burden for healthcare systems worldwide. Most of diabetic patients have more than one additional chronic disease, which is a problem for us. You see some examples here. Ocular complications we mostly encounter are diabetic retinopathy, diabetic macular edema, and also diabetic cataract, which is a topic. Diabetic retinopathy, just to remind you, is a microvascular abnormality that is chronically progressive and is a major cause of disability in working age, younger population. So in the essence, diabetic retinopathy is inflammatory disease. It is the result of damage of blood vessels which occlude. That process ends with neovascularization, and these blood vessels leak and cause edema. The final result is loss of visual function. So I was talking about something sweet, and this is a horror. We don't want to see this horror anymore, but we see it every day almost. We have to prevent this kind of proliferation. For example, this is iris neovascularization. I photoed this patient yesterday. So this is, again, one horror. This is a bad prognostic sign, resistant to treatment, and the blindness is a frequent consequence. Something about diabetic macular edema, it's the accumulation of fluid in the macula and is the most common cause of vision loss in diabetics. Helpfully, we have OCT and it's easy to diagnose. And also, we have various armory of weapons to treat it. And predominantly intravitreal injections of anti-VEGF and corticosteroids, and we also have laser photocoagulation, and in some cases we need to do the surgery. Now the topic, diabetic cataract, which seriously impairs the quality of life of our patients, but also it obscures the fundus, so we cannot diagnose and treat properly our patients, so it has to be removed. You all know the risk factors for development of cataract. In diabetic patients, the greatest changeable risk factor is glycemia level, so we have to deal with it. Why? Because it causes oxidative stress and osmotic swelling of the cataract, and also with polyol pathway, and some authors discuss the role of autoimmunity in developing of diabetic cataract. We also have to keep in mind that these patients are probably previously treated with frequent intravitreal injections, so especially corticosteroid injections, they cause cataract in diabetic patients. So that's why the cataracts are more frequent in diabetic patients, especially in younger group, 3 to 4 times more frequent than in healthy persons, and in older group, 2 times more frequent than in healthy persons. The 10-year cumulative incidence of cataract surgery in diabetics in type 1 is 8.3%, and in type 2, almost 25%. The predominant types of cataracts are cortical and posterior subcapsular cataracts. And they vary with, the incidence grows with the duration of diabetes and poor metabolic control. So we have to work on that. So in preoperative evaluation of diabetic cataract, we have to keep in mind that there is not only the cataract that's diminishing the visual acuity of that particular patient. We also have to cope with diabetic macular edema, which is usually present, and diabetic retinopathy, and we have to discuss with the patient that after cataract surgery, after we remove the cataract, the problems on the fundus will stay. He has to be aware of that. So we have to look for rubeosis of iris, neovascularization in the angle. We have to address the pupil dilation, because the pupils usually don't dilate as in healthy persons, and we have to cope, that's the most important, with the fundus changes. So we have to cope with diabetic macular edema, to treat it before, if it's possible, to treat severe proliferative diabetic retinopathy. We have to, if possible, do the fluorescent angiography, etc. In some cases, we have to do the phaco-vitrectomy. So what are the benefits of cataract surgery? So the patient quality of life rises. He has then better glycemic control. We are also satisfied as retina specialists to see the fundus. It allows us easier monitoring of the patient and treating the patient. But we have to have in mind some intraoperative considerations. After cataract surgery in diabetic patients, there is also a tendency to shrinkage or phimosis of the capsular axis. So we have to make enough wide, but not too wide, capsular axis. That's where I see the role of femto cataract surgery. We have to deal with poor pupil dilation. Like Professor Ricari said, in diabetic patients, they are more prone to loss of corneal endothelial cells. So we have to keep in mind also that factor. And some personal remarks, because these cataracts are usually of higher pressure inside. So we have to be careful while doing capsular axis. They are usually softer, and for me, harder to chop. Regarding lens choice in diabetic cataracts, larger optics are advisable, and with square edge design to prevent PCO. Regarding multifocal and accommodative IOLs, they are not forbidden, but the insertion of these kinds of lenses in diabetic patients is a bit controversial. That also works for silicone IOLs, because if you do the vitrectomy afterwards with silicone, it's disaster. It's not forbidden also, but it's recommended to avoid iris glow lenses if possible, because there is hypoxia of the iris and the risk of iris neovascularization. So, like I said, it's an inflammatory disease, so after cataract surgery, you expect inflammation of the anterior segment, you have an increased risk for progression of diabetic macular edema and diabetic retinopathy, so that's why you need to cope with it, if possible, before cataract surgery. You have the increased risk of endophthalmitis and epithelial defects and persistent corneal erosions. So, how to reduce these complications after cataract surgery? First, cope with the hyperglycemia. They have to have normal glucose blood levels, if possible. So you have to do the detailed preoperative evaluation with fundus examination, avoid, if possible, that's in every case, intraoperative complications. You have to adequately choose IOL, use antibiotics, which is standard at the end of the surgery. You have to deal with diabetic macular edema before cataract surgery, and later a prolonged use of anti-inflammatory drugs and careful monitoring of patient fundus after cataract surgery. So to conclude, the cataract, which is a leading cause of blindness, develops much more frequently in diabetic patients. Cataract surgery in diabetic patients should be performed early. I told why. The results are usually excellent, but you have to be careful. You have to do the detailed preoperative evaluation. You have to have good surgical technique, and post-operative monitoring is mandatory. So I said I'll talk about something sweet, but it's not so sweet after this talk. Thank you.
To conclude the session, we've got Dr. Serenak talking about case series for scleral fixation. Thank you, Dr. Serenak.
Hi, thanks. Okay, so I'll try and be very brief to get as quickly to your break as possible. We'll be talking about flanging in various situations of scleral fixation. When looking at the Primari Pfeiffer's videos, you almost get this calm feeling, this Mozart-like videos. You get a sense it's very easy. You can start and be very, very successful. However, I think this really can be easy, because now we have really good methods of minimal invasive scleral fixation surgery for battling with no capsular support patients, very tough cases that we used to be very afraid of. And I'm going to show to you our experiences in Maribor with such cases. So the main topic of this talk is flange. It's actually a term that's used in engineering. It represents a rim for strength or for attachment to another object, like in this pipe you see here. And Dr. Yamane popularized it in 2017 and even beforehand for transconjunctival intrascleral fixation of three-piece lenses, which you've seen extensively in Dr. Pfeiffer's videos. So basically, the main point is creating two limbus parallel scleral tunnels with the needle and feeding the haptics into the needles, externalizing them and cauterizing them, creating effectively a flange, a widening, which will then fixate this IOL to the sclera. There are some other options where we can use a flange. This is with 6-O-proline. A couple of authors worth mentioning here are Canabrava. He uses this for C-loop IOLs for fixation with first the 5-O. Now he only uses 6-O-proline. And there's Asia with his papers with 6-O-proline in usage of a variety of IOLs, capsular stabilizing devices. And one of the most interesting things is using them to salvage subluxed IOLs, which we've heard before, are getting more and more common. The population is getting older. We've done a lot of cataracts, and there will be some subluxations. And now we can effectively use minimally invasive surgery to salvage those lenses and not to explant them as we used to do it. So here in this slide, you can see on the right that you can create a loop with the 6-O-proline around the haptic and then fixate it to the sclera. On the under right photo, you can see two flanges which are radially parallel, fixating effectively the haptic to the sclera. There are also papers diving into the exact way you should create the flanges to have it as optimally as possible. And to make it short, basically you need to grasp the flange when cauterizing it about 1 millimeter away with a forceps and cauterize it for 1 millimeter. So it's like a square measure that you need to use to get a big enough flange to be able to fixate it and not too big for it to prolapse under the tenons and the conjunctiva. So the next slide is very busy. It was not my intention to show you all the techniques. However, I'll show you the group of patients in the last years where we used the flange. So basically 4 methods which I'll describe. The first group of patients is with aphakia, where we would use the Yamane technique, all known to you. The second is, and second and third is sublux 1-piece and the sublux 3-piece. For the 1-piece IOLs, we nowadays refixate all of them with the double-flanged 6-O-proline technique, where you, as shown on the previous slide, create a loop of proline under and over the haptic and just tighten it to the sclera. On the third group, we just externalize the PMA haptics and flange them. I call this a modified Yamane technique. And on this video especially, you can see the usage of capsular hooks, which I like to use sometimes, although Primari Pfeiffer says you don't need them. But sometimes it's nice to have a clear view and not to use the needle to retract the iris. So you can use those. And very useful if you have an ectopic lens and you don't want to explant the capsule, you want to salvage the capsule and want to implant an intracapsular lens. You can always use an intracapsular device. In this case, we use CTRs and fixating them with 2-point fixation using the 6-O-proline in a similar manner than fixating the subluxed IOL. So I hope that you could see some of the steps on these videos, that you could choose to see what you want. And I won't be stopping here for a long time. So if any of you have questions about the videos or technique, you can freely contact me through my email, okay? What we wanted to see is how much tilt we get. So we used the ultrasound biomicroscopy using the ultrasound, anterior ultrasound, and the OCT. And to skip the statistical overview, I'll just go to this table, where we can see that best corrected visual acuity was not our main goal, because the patients were very diverse with different other conditions, usually very complex. However, I can stress that more than 70% of them, we could get them very happy. Okay, their starting point was at around, in average, 0.1 Snellen, and more than 70% of them, we could get them over 0.8. The next thing what I want to say is that you can really well predict or position the lens with only 3.4 tilt, 3.4 degrees tilt. We had a really good result regarding the tilt, so not in many cases this was a problem, and we didn't affect the keratometry with tightening or anything like that. In initial cases, our results regarding the refractive surprises were a bit not so good. Then we switched target refraction to minus 0.75 or minus 1 to combat the more posterior position of the lens which we get. Okay, so about the tilt, I've said some of those didn't have a perfect tilt, but as said by my colleague, if you see the flanges, you can always go and revise the case, okay? You can lift the tenons up, externalize the flange, and just adjust the effective position, which we had to do in 2 cases, and those patients went really well afterwards. So what I recommend in measuring the tilt in those cases is using the OCT. It's quick and effective, but you can always also use the UBM. There's no significant difference in our hands. Regarding the complications, we had one hyphema that was very unfortunate in a glaucoma patient that resulted in subsequent trabeculectomy. This patient now is doing really well, actually better than before. He doesn't need any glaucoma drops now. And she's 1-0. In one case, we had a late exposed flange after 6 months. This was then surgically revised and resolved pharmacotherapeutically. And we have the 2 exposed flanges the next day. So what I do for the anesthesia, I usually use peribulbar local anesthesia, and this anesthesia. So this sometimes creates this hemosis of the conjunctiva, which can result in flange not being completely tucked into the scleral tunnel, which it should be. But you can very easily the next day use some alkane, some topical anesthetic, and just push the flange inside on the slit lamp. We had one chronic CME, which has been described by Amane as well, that this can create some CME, but this was in a patient that was already complicated beforehand with a resilient diabetic macular edema. At the end of this lecture, I would like to give you just some pearls, what I do, if you can use them, maybe modify your technique a bit. I find it very helpful to feed the first haptic with the IOL still in the cartridge, so I can use the right hand and the IOL to maneuver the haptic easily without using the Eckhart. And this is how I feed the first haptic. The first needle for the sclerotomy and the second, I bend the bevels towards me. They look towards me. I think it's easier to get the haptic in. And after I externalize both needles simultaneously, which you should do, I just leave the first haptic in the needle, throw it down on the sclera, so it has a bit more traction for it not to jump back into the eye, because this is very complicated then to solve. And just attend first to the second haptic, okay? In sublux 3-piece IOLs, it's very difficult to get the sclerotomies 180 degrees apart. So what I do is just go a bit anti-clockwise, maybe 2 millimeters away from me with the second haptic. So it's easier to feed the second haptic into the needle. And then you should shorten the first haptic just to get the proper centration. But as these 3-piece lenses, they have really good spherical aberration, almost none. It's the decentration is not that much of a problem. The problem is the tilt, okay? So you need to be in level with both haptics. A bit more tips about the 6-0 Prolene. It's very easy to use 2 tying forceps. You don't need to go into the eye with Eckhart or anything. You just put the suture first inside of the eye before going to sclerotomies. And then when you have the needle inside the eye, just go up external and very slowly push the Prolene into the needles. For each sclerotomy, because here usually you have 4 sclerotomies, and with Canabrava technique you need 4, right? You use different, so new needle for every sclerotomy, because they tend to lose their sharpness. What I tend to do also is use sharp scissors, like a Westcott from the plastic surgeons, and just cut the Prolene so it gets a bit pointy at the end, which makes it easier to thread into the needle. So with all of that, I thank you for your time, and I hope in this battle that I gave you some tips, maybe encouraged you to try some of the techniques. Thank you so much.
I think me and Dr. Dikaris will like to thank every speaker on this session. I think the session will be incomplete unless we, if you've got any questions, probably for any of the speakers, happy to take that. Any questions at all for any of the speakers?
The coffee break will be, don't worry, the coffee, we will just push the second session a little bit. So we know that we are eager for coffee, but there are some persons eager for knowledge. Please.
I have two small questions. First for you, Sanjay. You really made for that case of your pilot, not any monovision and even micro monovision, because he also had his board in front of him, which needs a little bit of minus.
Yeah.
That is my question for you. And for Dr. Predović, question after in your hospital where you work, do you have any endophthalmitis in these diabetic cataract patients, as we know that they are prone for inflammation after any surgery, and cataract surgery also?
Yeah, that's good. So for me, I would say it was probably learning with the patient, and I think now I've got a group of patients who are HGV drivers pilot, where I actually am truly almost going for, I never do bilateral surgeries in this. I would always do the dominant eye first. And I think because with one eye done, you could actually see the range of movement that they've got. Then you can slightly micro-monovision them. But there are some, like commercial pilots, they cannot have even unaided eye, cannot have 6/9 or sort of worse. So you need to actually concentrate on the distance and intermediate. And I think for HGV drivers, pilots, I think that's probably what my recommendation would be, to do plano in both eyes, actually. And you take a bit of a hit for very, very fine small print, but actually distance and intermediate is uninterrupted without any dysphotopsia and a good vision. Thank you.
Jurica.
And the second question, thank you for your question. I didn't have any endophthalmitis, but I found in literature that the rate is higher, maybe because I haven't performed so many cataract surgeries till now.
Yeah. Sure.
Go ahead. I have a question for Vlado. Can you comment, please, how do you decide you refine your artificial iris prior to the surgery? How do you decide on sizing of a refine? And do you have any post-op glaucomas?
Thank you for the question. So when we implant the artificial iris into the capsular bag, then we measure the capsular bag. And usually, then we refine to 9 millimeters. Okay. And when we are implanting the other techniques that has no support of the capsule, then we go usually to 10.5 millimeters. This iris comes 12.8. And we take just the refine, put it on a silicone, and refine it. And I'm always using a fiberless artificial iris. Okay. So if there is some contact, there is less trauma to the eye.
And pressure? Post-op pressure?
Oh, pressure. You don't have problems with the artificial iris if it doesn't touch an intraocular structure. The pressure is a problem of the uveitis. Okay. So, you know, if there is some contact, it looks nice. Can look nice for a year or two, and then troubles come. Pressure, uveitis, cystoid. Mostly it shows up with cystoid macular edema. And then you know something is wrong, and you have to reposition the iris, the artificial iris. Or you can lose the endothelial cells, and you have a real problem. So do the reposition as soon as possible.
Can you do it several times? Excuse me. Can you reposition like
yes,
down the line 3 times or how many times?
Sure. You have different techniques, like on a Brava. You just pull I want to have 4-point fixation, so I can pull in whatever direction I need to bring it out of the sulcus or whatever. Then I have these four flow suture techniques, which are they're just put into the sclera, and you can adjust it later on, years after the surgery if needed, or months or whatever. And the technique I've shown, I think, is not most suitable for repositioning the iris. But in this case, you can just turn the iris because it's not fixed. It's just true, you know.
Okay, thanks.
So,
Thank you.
Any other questions?
I have a question for you, if I can. These lenses, okay, what would you say is the perfect pupil measure diameter that these lenses have the maximum effect with positive spherical?
I would say,
yeah,
I would say people who've got, or if you use the other ones which has got negative spherical aberration, they're a bit more dependent on pupil size. I think I would say positive spherical aberration, fortunately, unless it's less than 2.5, which is very unusual, or it's a very, very sort of 6.75, you know, well-dilated pupil, except for these extreme ones, I would say actually photopic and mesopic is not massive difference in terms of the outcome. I do think we all know, even with trifocal or any extended range of focus lens, we always say your vision, at least your intermediate and near, will be better depending your light conditions. That's for sure. But I do think the range between 3 to 6, which is the normal ones, I don't think there's a huge difference.
Mm-hmm. Thank you. Because all these lenses with spherical, these optics, they are pupil dependent.
They are. They are.
Definitely. And
But
if you have a small pupil, there is no effect.
yeah.
Is it correct?
If it's got a myosed pupil, then you might actually get, so if you're using eye hands, for example, you'll actually get negative spherical aberration because it's right in the center. Otherwise, I think the normal 3 to 6 millimeter pupil size is not that variable, in my opinion. But they are, as you rightly say, pupil dependent because you need good light to get the best intermediate vision.
And with years, all these patients would get smaller and smaller pupils.
Later on, yes,
Yeah.
as they got older, absolutely, absolutely. Can I ask one last question before I go? You've both covered very, very well in terms of the flange technique and scleral sutured. Tell me, what conditions would you think, well, I'm just going to put an iris claw lens, retropupillary. Do you think there are some situations you'll say, well, this eye is not suitable for that much amount of manipulation? I mean, surgically, for you and your colleague, Dr. Cernak, presented really, really well, and you've got very good experience. Surgically is very satisfying, but there are some eyes, you could say, it's aphakic. I'm going to take this lens out. I'm going to put an iris clip lens in, flip it around, and put an iris, posterior fixated. Do you have any experience, or do you think, what's your opinion on that?
Yes, we have been doing iris claw lenses, retropupillary, until 2015. And I stopped totally when Yamane came in 2016 with the technique. Immediately I started with this. And I think this is much, much less trauma.
Okay.
You have to make a 5.5 millimeter incision. There is astigmatism.
Yeah.
In children, you have to suture it. It can make a problem.
Right.
It can leak. So I think the Yamane is a huge step forward in quality of vision and also in the
long term.
Yeah, long term and security.
Do you have any?
What I think is when you learn to trust the flange, it's obvious the choice you will take because it's the effective lens position and the anatomical conditions we have after Yamane or Canabrava technique are just superior to clawing anything to the iris. Okay. So I think, in my view, it's not obsolete. So there's probably some cases where sclera is not sufficient.
okay. I haven't seen a case till now like this, but it's not to abolish the iris claw lenses, but for the normal indications we had, I think, as Primari Pfeiffer said, we can use this method very well and we have good results.
Good, thank you very much. Well, I hope you will agree that that was a very interesting session. And yeah, the long-awaited coffee is here. Thank you very much, guys.